Okay.
Hello, can you hear me?
Hi, Dr. Sajid. How are you?
Yes, I'm fine. How are you?
Okay, I will do you a co-host, and then we will start.
Okay, thank you so much.
Mhm. Yeah, great.
Good evening. Assalamu alaikum,
Walaikum salam.
everybody.
Just I will
Thank you for
introduce
the
you.
invitation. Yes, please.
Just let me introduce you. Okay, just a little bit. I will share it on Facebook.
So, how much time we have, Dr. Negm?
Oh, sorry.
How much time we have today?
Just now. Okay. Assalamu alaikum. Hello, everybody, all attendee, for this amazing talk for my friend, Dr. Sajid Ali, one of the best tutor in electrodiagnosis. He is a lot of times do a lot of workshops, I think in Dubai, and also he is one of the consultant clinical neurophysiology at King Fahd City at Saudi Arabia. So I'm sure you all entertained with this talk with Dr. Sajid, and I'm sorry for this some late to start. So please start, Dr. Sajid. Yeah, go.
Okay, thank you so much for the introduction. Assalamu alaikum, good evening, everybody. So I'm just gonna start to share my slides. So how much time we have for the talk today?
I think you request 2 hours, just as you like.
Yeah, so okay. So we'll start off. I think somewhere between 1.5 to 2 hours we will inshallah finish. Okay. And we will give time for questions, inshallah. Okay.
Okay.
So if I everybody can see the slides.
Yeah.
Okay.
Great.
So so today's topic is a basic approach to nerve conduction studies. And now, for those who are already familiar with nerve conduction studies, we always take nerve conduction studies and electromyography or EMG as two parts of the same test. But a lot of times we may only be needing nerve conduction studies and we may not need the EMG part of it. So what I'm gonna do in the next sort of hour and a half is go through some basic techniques. First of all, go through some basic approach, how to approach a patient and how to decide why he needs nerve conduction studies. Okay, we go through some basic techniques, including sensory nerve techniques and motor nerve techniques, and then we will go a bit more technical and we'll see sort of layout for today's talk. See, whenever we think about nerve conduction studies, we already have seen the patient. So either if you are working in an electrodiagnostic lab, somebody has sent the patient to you. So somebody has taken history, physical examination, and come to the conclusion that this patient may have a problem affecting the peripheral nervous system. Now, whenever we encounter a patient in neurology, or whenever we encounter a patient to do with peripheral or central nervous system, we always have two essential questions that we want to ask. And one of them is that where is the lesion, which is localization of the lesion. And the second question is what is the lesion. Now with clinical history and examination, we can sort of define at least on the basis that this looks central nervous system, this looks which part of the cortex, spinal cord, peripheral nervous system, which part of that. But what nerve conduction studies help us is to further localize it. So we say that this is an extension of our neurological examination. So whenever we consider, we based on the history and the physical examination, we will always have a differential diagnosis. We will always try to think, okay, this looks like some problem in the peripheral nervous system. Now, which level of the peripheral nervous system is it to do with? So that is where this diagram comes into our mind. And this is a very basic schematic diagram of the peripheral nervous system. And I'm going to go through this first, because one diagram that I would, if you want to take home and sort of, put it in your mind, is this one. It's like I call it, it's like a mind map. So when you're looking at this diagram, it is showing you the different stations or the localizations of the peripheral nervous system. And always we approach this in a systematic way. So either we start from the proximal to distal or from distal to proximal. So consider it like it's a train station and it's got different stops. And you have to consider the clinical aspects of each of this and the variations in the clinical history and examination that would sort of make you point or go towards one of the stations. Now, when we use nerve conduction studies, we can very precisely locate the lesion at one of these stations. So we need to know what abnormalities or what combination of abnormalities in the nerve conduction data we will see that will help us point this out. Now, when we look at the peripheral nervous system disorders, we classify them according to this diagram as well. We try to put them into boxes, and that those classifications of the peripheral nervous disorders are based on these anatomical localizations. So right from starting from the level of the anterior horn cell or the motor neuron, we classify this as the motor neuronopathies. So all sort of motor neuronopathies come under this category: ALS, SMA, infectious motor neuronopathies, and others. And further, if we go down further, we see that there is involvement of the nerve root, where we have radiculopathies. The radiculopathy can be involving the cervical segments, can be involving the cerebral segments, but the etiology of the underlying would be within this sort of categories that I've listed in on the slide. Furthermore, we look at some of the rare types of abnormalities which are involving the dorsal root ganglion specifically. These are sensory neuronopathies. So we are approaching the peripheral nervous system, or we'll be classifying the different disorders of peripheral nervous system anatomically. So all of them, if you look at motor neuronopathy, it's the anatomical localization. Radiculopathy, sensory neuronopathy. And amongst the sensory neuronopathy, the most common one is the paraneoplastic or autoimmune etiologies that we should consider. And then in between, once the roots give rise to their branches, they form a plexus. In the neck region, they form the cervical plexus. In the lower leg region, the pelvis region, they form the lumbosacral plexus. And we know that different lesions can cause plexopathies, different etiologies, of which the common one is radiation-induced plexopathy, and other infiltrative such as neoplastic or diabetic plexopathies. Further going down the peripheral nervous system, we come across a different sort of peripheral neuropathies, and this may be one of the most commonest sort of indication where only nerve conduction studies may suffice to give us a very clear diagnosis. And we have a lot of sort of modalities, different parameters that we look at, and we can define pathology here as well. We can tell if it's a demyelinating process or if it is an axonal process, and we can look at the distribution of the abnormality as well. Going further down, the nerve ends at the neuromuscular junction. We can look at a different sort of spectrum of neuromuscular junction disorders. We can decide on the basis of nerve conduction and other specialized techniques such as repetitive nerve stimulation if the problem is a pre-synaptic problem or a post-synaptic problem. And furthermore, we go to the level of the muscle where we look at the muscle disorders, and we can tell what degree of muscle disorders we're looking at. Now, if you look at the whole peripheral nervous system, we are always looking at the data that is coming from the sensory nerves and the motor nerves. And usually we try to take one sort of a boundary or one sort of a borderline where we define things occurring before the level of the dorsal root ganglion. And we call them that they are preganglionic, whereas it's a very important anatomical landmark from a nerve conduction point of view, because we're looking at these conditions where the lesion is before the dorsal root ganglion, such as all motor neuronopathies, radiculopathies, whereas the dorsal root ganglion is intact. So you may have you may have a lesion involving the nerve root over here, but what happens is that the motor nerve root neuron is disconnected from its main parent or main nucleus, and you see that motor neuronopathy occurs already in a radiculopathy, and motor neuron loses its nerve supply, and eventually muscle becomes weak and becomes atrophied. Where the sensory responses are very well preserved, because the disc or the material which has come out and caused the radiculopathy is not involving the dorsal root ganglion, but it has involved the sensory root. So you may get sensory distribution symptoms, but when you record the nerve conduction response, the snap, it's preserved. Why? Because the nucleus which resides in the dorsal ganglion is intact, and the downgoing axon is intact. So when you record the response, it is preserved. So this is a very important landmark, that if you have sensory nerve responses preserved, you think about a preganglionic lesion, or if you have a sensory nerve involvement, then you call the lesion, localize the lesion at or after the level of the dorsal root ganglion as a post-ganglionic lesion. This is a very important anatomical sort of a landmark which we sort of always consider when looking at nerve conduction data. Now, in conditions which you guys, especially in rehab, come across a lot, is a traumatic nerve injury. And in traumatic nerve injury, if you get nerve root avulsion, and with nerve root avulsion, you can imagine that this is all very close. This is a schematic diagram. So consider this is the neck, and this is the arm, upper arm and shoulder region, and this is the brachial plexus region. So if you know, if you've got a traumatic nerve injury where there's pulling of the nerve roots as well as the plexus, you may get a picture which is both preganglionic and postganglionic. And there EMG will try to help you decide what is the level of the preganglionic nerve root avulsion and also what is the level of the part of the brachial plexus involvement. Is it upper trunk? Is it lower trunk? Is it more than that? And or is it a brachial plexopathy? Now, it is important to look at all of this information, just not because of localization. It is equally important to see, because if you're dealing with nerve root avulsion, you know clinically that this patient don't do very well. They have poor sort of recovery. They have poor prognosis. So also to prognosticate, it's important to just not localization, try to identify the pathology and as well as prognosticate. So it's very, very important to have this schematic diagram of the peripheral nervous system as a mind map. So I usually tell all my residents that, look at this diagram and put it in your mind, that part of the cortex which you can access very easily. You know, like you have a folder in your computer, on your picture, in your album, where all the important ones are. You put a star on it, or the favorite one. So put this diagram in one of the favorite part of your cortex, where you can retrieve it with very little effort. It's very important. Yes. Okay. And based on this, we will go further and see what sort of approach we have in localization. So if you look at overall the peripheral nervous system, all of these anatomical landmarks, we can divide them into 3 boxes. So we can divide them into 3 sort of pathologies involving 3 different structures. So those which are neuropathic disorders, we have already looked at the disorders involving neuronopathies, radiculopathy, plexopathy, mononeuropathy, which is the prime example is carpal tunnel syndrome, which we all look every day, multiple mononeuropathies or polyneuropathy. The myopathic box or the myopathic disorders are the ones which are involving the muscles. And based on our distribution of the abnormality, we can decide, we can tell if this is proximal, distal, generalized, and in neuromuscular junction, we can decide on the basis of RNS if this is presynaptic or postsynaptic. Now, we also use nerve connection studies to exclude peripheral nervous system disorder. So say that our all nerve connection studies and EMG, everything is normal, but the patient has some weakness which is not explained. And we do some EMG and we see specific findings that it means that the patient, there is a problem with activation. There is a problem which is more central. We can see specific EMG patterns that tell us this is a central tremulous sort of recruitment pattern. And that tells us this may be related to a central disorder such as myelopathy, such as stroke, or even some sort of psychogenic weakness, where the patient may be not truly weak and just have a psychological sort of ailment. So just not localization. If your localization, it also excludes that if this is not a peripheral nervous problem, it may be related to the central nervous system. And that is important for us to consider. And sometimes sometimes clinically we know that this looks like a psychogenic weakness. This looks like give-way weakness clinically. But we want to reassure the patient, because sometimes reassuring the patient, look, we've tested your nerves, your muscles, everything is perfectly fine. We can confirm that your peripheral nervous system is working very well. And that reassures the patient and they overcome their fear or whatever psychological problem they had, and it helps them overcome the problem. So at times we can just not localize, but we can exclude the problem which is related to the peripheral nervous system, and that confirms that maybe there is a central disorder, and you can direct the clinicians or yourself that we need to do more investigations for the central nervous system. Within the neuropathic disorder, we have just said we can identify which type of fibers are involved. Is it a pure motor neuropathy like in Aman? We see a variant of GBS. We know the prognosis is not very good. Is it sensory demyelinating neuropathy? We look at the pathology. Is it axonal demyelinating? Is it acquired in forms of GBS? Because all of this information is helping our management, is helping to prognosticate, is helping plan, especially from a rehab point of view, that if you're dealing with a man, you do an early rehab consultation, because this patient will require long-term rehab. If a patient has AIDP, you know that this is a demyelinating disorder, we have given the IVIG, we recover, we expect early recovery. So all of these information is helpful in integrating further managed plan. And obviously, we know the timeline of, we will discuss this later on, the timeline of how nerve conduction studies get affected. And based on that, we can tell if the problem is hyperacute, acute, subacute, or chronic. Within the myopathic, as I discussed earlier, we can tell if based on distribution, asymmetry, bulbar symptoms. Each type of myopathic disorder has a different differential, and this helps you guide your differential. A lot of diagnosis now is done with genetics, even muscle biopsies, they're not doing that much. So, but still the EMG is helpful in trying to guide the genetics. So which type of genetics you need to do. You don't know gonna be doing in every patient whole exon sequence. You want sort of, guide it. So sometimes, like when I work with my neuromuscular colleagues, they asked me specifically, look, we are suspecting a myopathy. So see if you have active denervation. Is it something of an inflammatory myopathy, or is it something of a hereditary myopathy which has muscle fiber destruction? Because then we will send some other sort of genetics. So we can sort of guide other investigations if we cannot even diagnose clearly. If we do not have presence of active denervation, we call it blend, and where we have myopathies because of steroid or statins or hyperthyroidism. I think statins still sometimes can give active denervation, but steroid myopathy usually doesn't give. And we call it like a bland or tasteless sort of, it doesn't show much active. And again, the temporal course based on the EMG findings. Already discussed within the neuromuscular junction, we can tell if based on distribution. So you may have a patient presenting only with bulbar symptoms, ptosis, okay? But when you do a single fiber EMG, you see abnormality in a limb muscle. Now this is not bulbar myasthenia. So you need to tell the patient your symptoms are bulbar, but you have a systemic myasthenia. And that is where it's very helpful to tell the patient right from the start that you may have a long-term illness, you may have later on immunotherapy, and we have to take you from that aspect. It's deciding about pre-synaptic, post-synaptic is very essential. It helps your management totally, and again, if the problem is acquired or inherited. Now, whenever we come to a patient, we in our encounter, it's a clinical encounter. It's just like any other clinical encounter with any other patient. So although we are going to do nerve conduction studies, but we are directed by our physical examination and history to formulate a differential diagnosis. Based on that differential diagnosis and this, keeping that our schematic diagram that we had a look in as our mind map to guide us, we decide which nerves are we going to do and which EMG muscles we're going to do when we go to the EMG part. Importantly, is the take-home message here is that never ever stick to a protocol. Now we make protocols for carpal tunnels, for peripheral neuropathy, because our technologist colleagues have a guided sort of this minimum nerves or muscles to test. That is why we make protocols. But protocols are made to get a certain standard there, but you always have to look at the results and be able to modify them as you go along. So it's a dynamic test. You are taking live results and interpreting them as you go along. And at that point, at that conjuncture, you need to decide, do you need to add another muscle or not? Do you need to add another nerve connection or not? Or this is suffice for your differential. So this is very important. Regardless of what protocol you follow, keep it dynamic, keep it so that you can be able to interpret the results before the patient is gone with respect to your differential diagnosis. Look at your differential diagnosis that you've excluded everything within it, so everything is normal. Or if you have not excluded something or some new findings have come, you may need to do more nerves. So you have to approach the patient in a very, very dynamic manner. And that is very important when you decide what protocol you're going to choose for that particular differential diagnosis. And I don't need to go through this. This is just, symptoms, how long they've been. You all know this better than anybody else because you're doing the clinical examination all the time. It has to be directed. It's basically sensory-motor directed examination because, see, if I am doing a nerve, let me go to the next slide. I explain this better here. So these are the cardinal rules of nerve conduction studies in EMG, that we say that it is an extension of our clinical examination. Very, very important to look at what the clinical problem is and always question whether the findings you are finding are relevant to the clinical problem. This is the most important thing. You need to have a clinical electrode diagnosis. And whenever you're in doubt, think of technical factors. For example, you are stimulating and you're not getting any responses. So go and check the cables. Sometimes your hand may touch the head box. The little small button on the head box was switched off. So head box is not connected at that time and you get a flat line. So these are little things, but they matter. You need to keep them in mind. And when you're in doubt, sometimes you may have data which is not fitting in with your clinical diagnosis, with the clinical examination. So for example, I'm doing a nerve conduction study and I just saw that I don't find a sural response on one side. So I see this doesn't fit in. I check my electrodes, I check my cable, everything is fine. And I'm still sure that this is an absent sural response. The patient has not complained of it. The patient has been referred for carpal tunnel for some reason or diabetic. And I said, okay, let me just do some lower limb. And the other sural is fine. The medial and the superficial peroneal is fine. I don't find this is fitting with a common sort of a peripheral neuropathy. So I examine the patient. I look at the pinprick area or the distribution of the sensory sural nerve, and I find that there is no sensation there. The patient, she doesn't feel it. And then I said, did you injure your foot? And then she recalled, oh yes, in childhood I had some injury and ankle surgery. And since then this patch has been numb and I never sort of even bother about it. It doesn't bother me. It's been there for ages. So now what I did was I was in doubt. I re-examined the patient and I found a clinical correlate of my electrophysiological finding, which was an absent sural nerve. And clinically, I saw that there is absent sensation in that. So now I have an explanation for my electrophysiological finding. So this is important. Sometimes you have to step back. Sometimes when you saw the patient initially, this may not have clicked you. These findings which are coming on nerve conduction is something new. So you go back and you see if you still can see the clinical correlate. And again, this comes back to the first one that you have now found a relevant sort of clinical explanation for your electrophysiological finding. And this is the most important crux of the matter, clinical electrophysiological correlation. Now, if you're in doubt, do not overcall the diagnosis. Now, you see, whenever we encounter a patient from a purely clinical aspect or even electrodiagnosis aspect, we saw a patient which has all nerve conduction velocities were slow. Sensory nerve conduction velocities were slow. Some motor were borderline slow as well. And I thought, oh, uniform slowing of all nerves, this may be a neuropathy. Because if I say this is a neuropathy, in my report, the patient is going to take that. He will undergo unnecessary investigations. He may go under necessary management and treatment with this diagnosis. So what have I done? I've done a type 1 error. So doing a type 1 error is that falsely labeling a patient with a diagnosis which the patient does not have. Now the problem may be that the patient hands and feet were cold. I did not take temperature. I did not adjust my findings for the temperature and I got all over slowing. So it doesn't fit in. So that is why if I would have said, well, you know what? I don't have a temperature probe. I cannot check. Maybe this is due to temperature. I cannot correct it. I cannot vomit. But let me repeat the test in a few months' time and see if this is true findings or not. Are these findings reproducible or not? So whenever you're in doubt, just mention your doubt, but don't overcall the diagnosis because you will commit type 1 error, which is more dangerous than doing a type 2 error where you may miss the diagnosis, but because you have called the patient back for follow-up, you will eventually pick it up. Or the patient will go further back to the clinician or ourselves in your clinic and tell, oh, my symptoms are not getting better. And this happens a lot of time with carpal tunnel. A lot of times patients come with typical symptoms of carpal tunnel syndrome. And if your nerve conduction is normal, it doesn't mean they don't have carpal tunnel because carpal tunnel is a clinical diagnosis. So we say that 10% of, or even sometimes more patients may have normal nerve conduction studies. And we always tell them, okay, treat it, conservatively, repeat the study 3 months, 6 months, and we'll see how we'll take the patient with us and progress further. So very important is that never overcall the diagnosis because that will lead you to sort of mismanagement of the patient and the patient will suffer eventually. So this is just briefly going through how to approach patients with nerve conduction studies and how to sort of clinically decide which nerve conduction studies you need to do and how to interpret the results accordingly. Now coming to the technical part or technique of then motor and sensory nerve conduction studies, there's always a debate of how to start off with your nerve conduction studies. Do you start off with first by doing motor nerve conduction studies, or do you start off first by doing sensory nerve conduction studies? See, there's no hard and fast rule. It's entirely up to how you practice. Whatever you do is how, and I think it depends on how you're trained to do it. If you're trained to do sensory first, do sensory first. Because I find that whatever I do, if I do it routinely, it becomes like reflex. And it's like pattern recognition. So I have this sort of a flow in my work. My work is easy, it is flawless, it is flowing very well from one nerve to the other, and I'm not missing out any nerve. So it's very important to have that flow. So if you're tuned in to do sensory first and then motor, fine. If you're tuned in to do, I'll do first lower limbs, sensory motor, both, maybe first sensory, then motor, then go upper limb, sensory motor, that combination, fine. It all depends, whatever. But importantly is that some considerations you can consider. So motor nerves we know are thicker nerves. They have high or thick myelin. They are recorded easily, stimulated. They are recorded easily. They have a bigger responses. We call the CMAPs, and we record them in millivolts. Now, anatomically, they're easy to locate because they're thicker and more importantly. So if I'm looking at a patient with carpal tunnel, if I do motor first, then I can find the motor response easily and I can know where my motor nerve is. So when I come to the sensory part, I know exactly where the location of the motor nerve is. And when I record, I know where to stimulate and where to place the electrodes if I'm doing orthodromic studies. So important is that it helps us to know the anatomy of that particular patient, and it's easy to stimulate and record because it is bigger responses. They are less contaminable from the surrounding artifacts or electrical disturbances. If you do sensory nerve conduction studies, these are smaller responses. You may have disturbance because of cable. We will look at this in technical aspects more in detail, but it may sort of give you more sort of trouble trying to find the threshold, the exact location, and you may waste more time initially with sensory nerve conduction studies. So doing motor has an advantage here. Okay, that's one aspect. Now you have a patient who is very apprehensive. That patient is a bit worried. Her friend had nerve conduction studies, and she told her that you know what, you're going to be electrocuted. They're going to give you shocks. It's terrible. I couldn't tolerate it. And now the patient is coming. She is apprehensive. She's sweating already. And in this patient, you need to reassure her, you need to convince her, let her relax, sit down, talk about it. And here, if you start motor first, motor are thicker nerves, so need higher intensity, higher threshold. You may have to give higher stimulus. This is the patient that you don't want to start with high stimulus. So here, starting with sensory has an advantage because you start with lower intensity, you get a response, the patient habituates a bit, and by the time you go to motor, the patient is fine and relaxed and can tolerate the motor responses better. So you judge accordingly to the situation, and you can decide which studies you want to do first. Now, when we do motor nerve conduction studies, so just let's look at this. We will follow this video as we go along the slides. Let's just look at it, pause it and look at it right now. So this is the arrangement of recording electrodes for a motor nerve conduction studies. So what we have over here is that we have a recording electrode placed on the muscle belly, and this is connected to a cable which is black ended, and then we have 3 to 4 centimeter away on the tendon, the other electrode placed. Okay. Now this arrangement is whenever we place any electrodes in any sort of a manner, we call it a montage. So this is the muscle belly tendon montage, okay, which we usually use for motor recording. Okay. Now the principle of all neurophysiological recording is very simple. It's simple that you take an electrical input from one side and you take the electrical input from the other side and you put them into a box which we call the differential amplifier. Okay, and what this does is that it takes the input 1 and input 2 and sees them as a mirror image and sees the differences between them and amplifies the difference and gives us that over here. Okay, so whatever is coming from this electrode, say it has an electrical current of 10 millivolts, and whatever coming from a tendon is 0. So we know that the difference is 10 and it is all coming from this electrode. So we know it is a response from the muscle. So this is the basic sort of principle that we apply to all electrophysiological recordings, that we record the potential difference between 2 points, and the differential amplifier sort of calculates and cancels out those waveforms which are the same in frequency and amplitude, and gives us the difference in the latencies and the frequencies and the amplitudes, and amplifies it and displays it on our screen. That is the simplistic way I can explain right now, although there is a whole talk on differential amplifier, but I'll keep it simple for the sake of understanding. So whatever we're recording is a potential difference between 2 points. That is we can never say that this is absolutely coming from point A or this is absolutely coming from point B. It's a potential difference, and this is a concept that we need to understand very well. Now, the other aspect of this is that we have an electrode in the middle over here, which is placed as a ground electrode. Usually we try to place the ground electrode between the recording and the stimulating electrodes. I sometimes place it on the back of the hand where it is not in the way. Here is, in this video, is placed over here. Now we go to the other part, which is the stimulator. So we see this whole structure that we have in our hand. It has 2 pins. We see this light is lighting over here. So whenever the light is lighting, that is the cathode, whereas the other end is the anode. And an electrical pulse is given, which sort of, gives a small electrical stimulation. So the stimulator gives an electrical pulse, which basically makes a change in a small electrical field just beneath it, which is for few millimeter radius, just to reach to the nerve, and which changes the electrical resting potential of the nerve. And therefore, the positive ions go inside and the negative ions come outside, as we know the physiology of what happens, and the pulse is propagated, which then jumps from one node of Xenvia to the other, because what we're recording are the myelinated nerves, as you can see in the small picture, and then it goes all the way to the end, to the terminal axon, where it releases acetylcholine, which diffuses out into the postsynaptic membrane and causes postsynaptic, attaches to the postsynaptic receptors, and which initiates, may reach a threshold. And if it reaches a threshold, then it causes a postsynaptic membrane depolarization. So the journey is of an electrical pulse, which initiates a nerve potential, which travels down, and then it initiates a muscle potential, and that is what we record, and we call it a compound muscle action potential. And we just see in the next few slides how this works further. Now, what we record from the muscle is actually representing the nerve, although we are recording from the muscle. So all the number of axons that we stimulated by this electrical pulse, they eventually lead to muscle fiber action potentials. And our electrode is placed over here on the surface of the muscle. So it is sort of looking down under all the muscle fibers underneath and recording each muscle action potential. And on the surface, they all come up and they summate together. And that is what we record as over here. And we get an upper deflection, which comes down. And we call this is the not one muscle action potential, but the muscle fiber potential of all the fibers under the electrode stimulated by the electrical pulse. So it is not one potential, it is a compound muscle action potential. And that is why we call the name CMAP, CMAP. Now we can also see, so this response, this height of this response from the baseline to the peak is what we term the name amplitude. Okay. Now we can see before the amplitude, there is a period where nothing is happening. There's a straight line. So this sort of spike over here is the stimulus artifact. This shows that an electrical pulse has been given. Usually in nerve conduction studies, we are recording near potentials, okay, because our electrodes are placed on the nerves. But if somebody asks you what is the far potential, which is recorded in nerve conduction, so this is the only potential which is the far potential, which is a stimulus artifact. Because the stimulus is given far, but it does relay the pulse or this spike to the electrode, and we record this at this start, this spike, stimulus artifact. So our journey starting point is this basically, and the journey is silent until we get under the electrode. And this silent period is the period or time the pulse takes to travel from the electrical stimulation to the point of the electrode over here. Okay, so whenever there is a period, there is a time, there is a latent period, and we call this as the latency. Okay, so this is the second thing that we sort of record. We'll come to the area and duration. So what we're going to look at is how this recording is done and what are the parameters that we record and what they mean. So two things I've said, amplitude and latency so far. Now, when we do this recording, so the motor responses are recorded in millivolts. Those are the settings that we look at. But then we look at what we call supra maximum stimulation in motor conduction. I think the next few slides will explain that better. So this is the same sort of diagram. We will go to the video again back, but let's look at this now. So this is the schematic diagram. Courtesy Sanjeev Nandekar, we are thankful that he's provided his EMG slides and material resources free for this period, and I've taken the courtesy of with his permission for this lecture, some of these slides from his website. So this is the same stimulator over here. This is schematic diagram. We have the cathode, which is usually black, and the anode, which is red, and these are the recording electrodes on the muscle. Now these are the nerve, whole nerve with the axons inside. So we give a small intensity, low intensity stimulation. Okay, we see that it is not reaching the nerve fibers. It is only limited to a few millimeters below the skin surface. And the baseline is straight, nothing happens. Now we give what is called a threshold intensity. So threshold is where you get the first fiber firing, okay, or first stimulation of the axons. And we see that one of the axons over here is activated and the pulse travels in both direction, antidromic and orthodromic. And when it reaches the electrode, we get this little response coming up. Now this is a single fiber where we have stimulated this over here, okay? And the action potential we've recorded is from a single fiber unit action potential, so we call it a SMUAP. Now further, let's just break this into and see what is happening. So what is happening with this single muscle fiber is that this axon stimulates or activates all the end plates supplies of all the muscle fibers from each muscle fiber. So different end plates are supplied and they all summate and we get this single muscle fiber potential. So this is what is happening at a more sort of a lower level inside the muscle. Going back to that, what we did over here is that now we have increased the intensity. So we have more fibers stimulated, or at least 3 fibers, almost 50% of the nerve is stimulated. We see that the response is becoming bigger now. So what is happening? The potential from these fibers, all these nerve fibers are stimulating the muscle fibers are summating now, and we're getting a bigger response. So still we are sub-maximum. We go further and we get set all the impulse is now stimulating the whole of the nerve now. Okay, all the muscle axons are stimulated and we get a bigger sort of a upright sort of a response, a full CMAP here. Okay, now this is where the concept of maximum to supra maximum comes in. We want to ensure that all the nerve fibers are stimulated. So we are increasing stimulation by very little degrees. And this is very important. Please don't jump very high intensities, because one, your patient will be uncomfortable. Secondly, you won't know where was maximum, where was supra maximum. You may straight go to supra maximum. You won't know where is threshold because you didn't start from little stimulations. You need to see the CMAP build up gradually in gradations. Don't be in a hurry. You give one big stimulation, you get the full response. But then you don't know if the response by going up, where did it change its shape? Where did it develop shouldering? Where another nerve core stimulation came in? So that is why I usually go in 4 to 5 milliamp increments, slowly going up to. Now, when I go to this level and I see that at this level, it is not increasing anymore. So this is my maximum intensity. Okay, it means I'm sure I've stimulated all of the nerve fibers. Now what I do next is that I increase this intensity to 15 to 20%. And this is what we call supra maximum intensity. We want to be 100% sure that all the axons are stimulated. So you see that the pulse becomes a bit more stronger, but the response does not change. It's the same. Okay. It means that now I'm satisfied. I have achieved supra maximum intensity, and I have also the shape has not changed. If this response would have become like this, it means this shouldering has occurred, and it means my supra maximum intensity has caused co-stimulation, or some ulnar fibers have come in stimulation. So this is very, very important that your shape is maintained. And you can only achieve this when you go with slow stimulations. And we'll see this more when we go for proximal stimulation as well. So this is just looking at how we achieve supra maximum intensity, how we go from little intensity to the supramax, and how we observe our CMAP waveform, and we don't want it to be changing its shape. We want it to go bigger, but we do not want it to change its shape. Okay, so having done that, let's go back to that video because we have few things to look in it. Sorry, let me just remove this mess. Yeah. So we have achieved by this stimulation a distal stimulation. Okay, so distal stimulating at the wrist. And then we stimulate more proximally. So why do we do that? That is the concept I'm coming to now. Okay. Now look, we looked at the amplitude. The height of the response is the amplitude. It represents the number of axons. As many axons we stimulate, we get the full amplitude. Okay. Then we looked how much time it took to travel from the electrical stimulator to the recording electrode, and we said that was the latency. Okay, and because latency is the time, and in this diagram we can see over here that the latency is dependent on how fast it's traveling in the nerve. And we know that in myelinated nerve fiber, it travels from one node of Zenwave to the other. It's like a saltatory conduction or jumping from one node to the other. And this, it is achieved by the way the myelin is. So the myelin is the function by which it has these interruptions in it, which makes the node of Zenwave, and that is why we have fast conducting myelinated fibers. So we know that the latency is dependent on this myelin. So right now I'm trying to build the concept. The myelin function is represented by the latency. The axonal function here is represented by the amplitude so far. Now we want to know how fast is this nerve traveling. And for this reason, we go back to stimulate the proximal end. Because the problem over here is that if we do not stimulate, so let me get back to here. Look, if I would have stimulated from here to here, so I can get I need to know how fast the conduction is traveling. Okay, so when we are driving a car, what is the parameter that we look at? How fast a car is going? Speed. And when speed is going in one direction, we call it a velocity. That is our high school physics. Okay, so what we do is that I will come to the principle a bit later. I just want to show you the diagram and the movie so that you can look at the stimulation proximally, how it's done. And then I will explain why we do this in the next slides. So we have got supramax over there. We come proximally, we stimulate at the elbow, the median nerve. Just make it run a bit faster. So I'm trying to adjust the, the stimulator at the proper place. Now I get the response.
Yeah.
And then I measure between the 2 points. So I just wanted to show you this, and now I'll explain this in the next slides. Okay, here. Again, schematic diagram of what I just explained to you. So my first stimulation was from this point to this point. Okay. Now when I observe, I see that the nerve had to travel through the axon, then it went through the neuromuscular junction at this point, and then it traveled into the muscle, and then I got the response. But I want to know the speed or how fast the nerve is traveling in only nerve. I don't need neuromuscular junction, I don't need muscle. So this time is not only travel time in the nerve, it has a time traveling within the neuromuscular junction and muscle as well. So that is why I go back and I stimulate proximally the elbow. Now, the machine gives me first the time it took from here to here as I call it the distal latency. Say this is 4 milliseconds. Okay. Now I go to back and I stimulate over here. Obviously, now the nerve pulse electrical pulse has to travel more distance. So it is traveling all the way from here till here. It will take more time. So it took 10 milliseconds. Now, I am very, what I know is that between this stimulation and this, it is only nerve. This and this is the only nerve segment. So I measure the distance as I showed in the video in between this, and I put the distance over here. And remember the distance, sometimes the machine may record it in centimeter or some may record it in millimeter. If it's in centimeter, we multiply by 10, we get millimeter. Okay. And then I want to know what time it took for the pulse between these 2 points, because this is the distance I'm interested in, because this is only nerve distance. And this distance I can calculate, or this latency or this time I can calculate by subtracting this time from all of this time. So, which will mean 10 minus 4, very simple. So this will be 6 milliseconds. So this is why we stimulate proximally, so that we can able to record the conduction, calculate the conduction velocity between only true nerve segment, and we remove all the part or the delay in the neuromuscular junction and the muscle. So I hope that was why I'm going to some very basics, and I'm sure most of you already understand this, but just for the sake of understanding and building the concepts. Now, again, it's important to look over here. So this formula, if I write it separately over here, is conduction velocity is equal to distance upon latency difference or time. If I just put latency. Okay. Now, we said distance is fixed.
Yes.
Okay. So I can also show this one as conduction velocity is inversely proportional to 1 upon latency. Okay. So now I know with this formula, whenever the latency will increase, what happens to the other one? It goes down. Whenever there is inverse relationship, one increases, other goes down. So it means that my conduction velocity is dependent on latency. This means that conduction velocity is also a function of the myelin. So as my myelinate in demyelination, my latencies will become very prolonged and my conduction velocities will become very slow. So 3 things we have done is amplitude, latency, and now conduction velocity. Okay. Now the good news is that we don't have to do all this calculation. When we're doing nerve conduction studies, we stimulate distal, we stimulate proximal, we put in the distance, the machine and the software gives us the latency, the conduction velocity. This calculation and subtraction of distal and proximal, all done within the machine software itself. We don't have to worry about it. But we just need to understand, because if we don't understand this, we won't know which latency we have to look at. I'll show you some pictures of the machine, which latencies you have to look for to know is it a demyelinating lesion or not. So here it is. So this is just showing another sort of a still diagram, of how this looks like. So this was our initial distal stimulation. This is our proximal stimulation. Okay. Now the latency that we're looking over here, look at this one. This is 3.2. This is distal one from there to there. And then 7.35 is the second one. Now, very importantly, if you know what your divisions are, you can easily calculate them. Okay. So if you look closely over here, this is 2 milliseconds per division. Okay. So if I know from 1 dot to dot is 2, second dot 2 plus 2 will be 4. Now this is slightly between, from the middle point, if this is middle point, this would be 3. But this is slightly more than 3, so here it's 3.2. So even if you don't have this table, if you know your divisions and your representation, you can calculate your latency very easily. Similarly, if you say this is 2, this is 4, this is 6. Now this should have been 8. Now this is In the middle, it would be 7, but this is slightly more than 7, so 7.3 around. So you can calculate them that way, okay? And what we calculated, the difference between is not showing here. So important to know is that this will never show the difference. So 7.3 minus 2. For 3.2 will be around, I think 4.1 or something. So if you divide 4.1 with 220 centimeter, converting it into millimeter by 220, you will get 53. You can do this if you want to in your calculator. So 220 divided by 4.1 will give you around 53 something. So if you don't have this table with you, it doesn't matter. If you know your divisions are marked, what is the scale, you can easily calculate it. Similarly, this one box is, this axis is amplitude, 2 millimeter per division. So if you take this as baseline 1, 2, 3, well, it should be around 3.5. So 6.5 or something amplitude. Look over here, 6.7. Okay. So this is where your latency, the first one is what you want to consider. If you take one thing, that latency is always the first one. Some people, where it is labeled latency only. Some machines label it DML, distal motor latency. So in your system, you would know how is labeling is done. It can be variable. Important thing to remember is the unit. The unit will always be millisecond, and it can tell you. And the one which is the distal stimulation at wrist is the one that you need to know. And this is the one that we consider when we consider how prolonged the latency is, to consider demyelinating criteria or not. Okay. The second latency we don't worry about. Okay. The machine has done the calculation. We don't need to worry about anything else. We just do first stimulation, second stimulation, put in distance, you get your conduction loss. Simple, very straightforward. So other parameter is amplitude. Okay, amplitude, look at the parameter, the unit is millivolt. You can always tell if this is millivolt, oh, this is a motor response, because we calculate millivolt motor response in millivolts, not in microvolts. That was sensory. And the third one is the conduction loss. So these things we need to remember, and if we focus on these three things, we will be able to decide if this is a primarily axonal problem or this primarily demyelinating problem. Let us talk briefly about duration. So duration, we say that where the response sort of leaves the baseline and then comes back to baseline. So this is what we call duration. Now, duration is a measure of synchrony. Now, what is synchrony? Let us, it's just like music. Everything is, the whole orchestra is working together. But I'm not going to give the example of music. I'm giving you the example of horses. So look at these horses, they come all together very on the finish line, very near to each other. So if I plot each one of these horses and the arrival time, I get a smooth graph of their arrival times, and they all sort of reach more or less at the same time. So I say that they are very synchronized. So these are like muscle fiber action potentials, each muscle fiber potential coming to under the electrode, which is taking like a flash picture and is seeing all of them together. We see a smooth waveform. Okay. In the second diagram, we see that these horses are arriving at different timings. Okay. So if I plot this one which came first over here, the second one, third one, and so forth, and the last one probably here, now I see that my waveform is sort of spread out. Another word for it is that it is dispersed. And it is dispersed. How? It is dispersed in time. That each horse or each muscle fiber, single muscle fiber potential is arriving at electrode at different time. And when we graph that algorithmically, we get a response which is spread out. It is dispersed in time or it is temporally dispersed. So whenever we have an increased duration, we are looking at a pattern of a response where it is showing temporal dispersion. Okay. Now again, why is it showing temporal dispersion? Is it because of axonal problem? Is it because of myelin problem? Let us look at the next diagram. So we're just gonna tease this out and understand the concept behind temporal dispersion. Why does it occur? Look at the first diagram. We see nice myelinated axons. We see nice myelinated normal axons. We stimulate over here. We get a nice smooth response. Okay, all arrive synchronized. Their duration is normal. Okay. We stimulate proximally. Again, we see that the myelin is all intact throughout all the nerve fibers. And we see the response a bit later on because it is stimulated proximally. Again, very smooth, normal. Okay. Look at the lower diagram. We stimulate the first one and we get a response where all the mechanisms are fine except this last one. Now this is very little defect in myelin. It didn't affect the rest of them. They all arrive fine. We get a nice symmetric response. But look at what is happening with the proximal. Here we have big chunks of myelin missing out. So one fiber is arriving late here. One is arriving here. One is arriving here. One is arriving here. And maybe just one is arriving here. So here we see that the response is dispersed because the myelin is disrupted, and it is not uniformly disrupted. It is disrupted in patchiness, this patchy disruption of myelin, okay, which is causing dyssynchrony of the muscle action potentials, muscle fiber action potentials arriving under the electrode, and which is causing to the graph or the waveform to becoming dispersed or in time or temporally dispersed. Now, what condition can we have patchy demyelination? When there are antibodies attacking the myelin all at once. So there is a shower of antibodies and they come and they destroy the myelin here, there, wherever they can get their hands on. Okay, so it's a patchy demyelination, means that it is sort of a attack on the myelin which is occurring all at once and in a patchy way, and that happens in acquired demyelination, in Guillain-Barré syndrome, in CIDP, whatever the etiology is. Okay, so we see temporal dispersion in acquired demyelination. So if you remember the patchiness which is causing temporal dispersion, you remember the antibodies coming and attacking in a patchy way, you will always remember this. Now, what happens if the myelin was not normal right from utero? The myelin was defective right from in utero or was not there at all. So the second response will have, so there's no myelin at all. First response is this much. Second response is very much delayed, but all are arriving at the same time. So see a smooth response, but delayed. It is very much delayed. So it is very, very slow because myelin is not there or it's totally dysfunctional, but it is not patchy. That is why the synchrony is still there, but it is all delayed. So you get very slow conduction velocity, you get very prolonged latency, but you do not get temporal dispersion. So this is where it is hereditary problem in utero, right from birth. So you can differentiate if it is a acquired demyelination or hereditary demyelination based on the presence of temporal dispersion. Now, one thing more has happened over here, if you pay attention, is that this response has dropped down. We said the height or the amplitude over here is significantly reduced, more than 50% reduced. And this is what we call the conduction block. So a lot of time you have conduction block plus you have temporal dispersion. The conduction block can sometimes occur in hereditary neuropathies as well. Type 4 CMT, X-linked CMT, CMT, other some variations, they can come with conduction block. But so only conduction block does not mean this is acquired demyelination. It can occur in hereditary as well. But when you see temporal dispersion, this is the hallmark of acquired demyelination. Okay. Now, one last thing that we also consider when we talk about conduction block is what we call area under the curve. Now, area under the curve is something that we cannot calculate. This is the software which calculates for us. Okay, the software will calculate the area. You have to go into the setup and tick that you want the area, and it will give you an area, and it will give you the area of the proximal, and also it will compare the difference in both area and percentage. And if there is a drop in area, it will tell you that there is 50% drop in area or 70% drop in area, whatever. Now, the problem with area is that, is it usually always drop with amplitude or not? That is an important concept that I'm going to explain next. So, only drop in amplitude is conduction block. But if you want to really define conduction block, you want to have a drop in area as well, because then you know that pure axonal loss has occurred. Pure sort of conduction block is happening, where there's no 50% of the axons are not functioning, and that is why there is a drop, just not in amplitude but area. Now, how do you differentiate that? Because see, if I have this colored red area, I may have this colored red area. It's just spread out. That one is all going up and down. This is going sideways. It could be the same area, although the amplitude has dropped. I can see it visually that this height of the amplitude, sorry, if I take, is now very less here. Okay, so let's go into one further step to see how drop in area has to be. Now, this is something that will show in the machine. There's no way of calculating. It's the number that you will see, the drop in area. So maybe the amplitude has come down, but the area is spread out. It means it is not a true conduction block. You need a drop of 50% area as well as amplitude to define your conduction block. If you have the function of area in your machine, if you don't want to use it, that's fine. You can keep your conduction block relative only to amplitude. Okay. Now understand this. In the first part, I made 3 apartment building complex. Okay. This is apartment number 1, apartment number 2, apartment number 3. I say that each apartment is 1000 square feet area. Square feet, okay, or I can do square feet like this to the power 2. So overall, how much area I have? 3 apartments, I have 3000. 3000 square feet covered area. 3 apartment buildings side by side. Now this area is the same if I make the apartment complex on top of each other. Apartment number 2, 3 and 4. Again, it is a 3000 square feet area. Agree? I have equal to sign. This area is equal. Now this area, height of this sort of building is the amplitude. Whereas the red covered area is the area. Now for a true conduction block, I want a drop in the height as well as the area. If I make height drop and the area still is the same, that is not a true conduction block. So for a true conduction block, I need 50% drop in area as well as amplitude. Yes, I hope that concept is understood. Now let us recap what modalities we have looked at. Let us go back and look at what are we recording from. We are recording from a nerve. We are looking purely at nerve function. We are looking at nerve physiology or pathology. So in the nerve, we have 2 components that we are interested in, the axon, obviously, and the myelin. And that is the crux of the problem that we are looking at. Is it demyelinating or is it axonal? That is the one big question that we are answering if you're looking at a neuropathy. So the structure, the modalities that are affected or are responsible for the myelin function, let us recap. We said the first one was latency because the pulse took its time to go over there from one pulse to the other based on latency. So when we look at this, we want to look at the latency, and we see that if the latency is prolonged, then it is a demyelinating or primarily a myelin dysfunction. Okay. And I put 3 arrows there because I want really high prolonged sort of latencies, not borderline. And we will look at the criteria in a while. Conduction velocity is conversely inversely proportional, so significant drop in conduction velocity. Both of these are representing the myelin function. Okay, and the third one was the duration, what we looked at temporal dispersion and conduction block, which is defining the myelin. So all of these functions are defined in myelin, whereas the axonal function is by the height of the amplitude, the height of the response, the amplitude. In the motor, it is snap, CMAP, and the sensory is snap. So this hopefully sort of categorizes our concepts and when to call something demyelinating and when to call something axonal. When we have these concepts clear, then it is very easy to understand the criteria. If I bring the criteria, it's very difficult to understand numbers. This 130% of that, 130% of this. How can you understand if you don't have the concept? So the whole exercise was to build the concept, and then we go to the criteria, which will come to the clinical application part. The fourth criteria is also the FF. We are not discussing here, but the FF latency is also a latency. So because it is a latency, the same rule applies as the normal distal latency, and it is again prolonged latency that we say that is the fourth criteria for demyelination. So 4 functions for demyelination and 1 function for main axonal, and the combination of this decides which is the primary process. Let us briefly look at the sensitivity of conduction studies. Here things are very simple. We don't have neuromuscular junction. We don't have muscle. And what we have is straightforward one end of the nerve stimulating from the cathode and recording from the anode. One thing I did not mention over there in the motor is that distance measuring. We have to measure distances according to the technique we're using. For motor median 7 to 8 depending on which technique you're following. And here usually we use 14 centimeter. This is very, very important. From one patient to other patient, your hand size may vary. You keep same distances because your data should be reproducible across your population. And the ground is over there. So here you have a stimulator going electrical pulse and then straightforward nerve action potential you record in directly. The same rules applies for amplitude, same parameter, height of the response, stimulus artifact you can see over here. And then you have latency where you see the onset, but also you have a peak latency. And the reason for the peak latency is that sometimes if you do not mark the latency clearly onset, you take the peak which is always there. It is useful. Usually you don't use the peak to calculate conduction velocity because it is more coming from the slower component. It's not representing the fastest conducting fibers, but it is useful to use it as a comparison from other nerves. So if you're using carpal tunnel sort of comparison to other responses or any other sort of, you can use the peak latencies. Usually we use them only in sensory because whenever our onset is not very clear, you can use them. But important thing is that usually it's more to do with your comparison of your useful in your comparison studies in carpal tunnel or any other study. Important thing again that we always use the average technique because sensory responses are very small. They have disturbance because once we sort of start to record them, we sort of repeat them 5 to 10 traces, and so that we can see they're more better superimposed, summated responses, and they smooth out as well. And we will see that when we see the video in the next slide. So two types of sensory studies we do. One is the antidromic and one is the orthodromic. So just to show you the video and the setting. So if I show this now briefly, quickly. So here I'm stimulating the motor nerve. I'm stimulating the main nerve, the main trunk of the median nerve, and I'm recording from the distal digital branch of the median nerve from the second digit. So my pulse is going in this direction. Okay. Here I've hooked the rings into the stimulator. I'm stimulating the digital branch, and my pulse is going this way, and I'm recording from the main trunk. Both ways we are recording the sensory signal. Be very, very clear. Okay. Why? Because here we stimulate the main trunk, but our recording camera is on the sensory nerve. Okay. Here we stimulate the sensory nerve, but our recording camera is on the main nerve. But because we have stimulated the sensory nerve, only the sensory fibers in the main trunk will be stimulated. Okay. So this is how the sensation go from the periphery. We have a sensation over here going to the central. And this is how sensory nerves conduct themselves naturally. And that is why we call this orthodromic, going along with the sensation, normal sensation. Whereas here we opposite and stimulating opposite direction, so we call it antidromic. Okay, advantage and disadvantages. Antidromic, higher amplitude. You can see over here, very nice clean amplitude, 33 microvolt. Disadvantage, lower amplitude. You can see over here, smaller amplitude. Okay, disadvantage here, you can stimulate the main trunk, some of the motor fibers can be stimulated, and these may cause a bit of volume conduction of the muscle response to the electrode, and you get this big response over here. Here you do not have this because you're only stimulating the nerve, there's no muscle here and the finger, it's only nerve under the stimulator. That is why you get a very clean sort of a signal, okay? So these are advantages. You have normative data for antidromic, you have normative data for orthodromic. It depends whichever you want to do. Most of the people, when I train in the UK, we always do orthodromic over there. Here in Saudi, everybody does antidromic first. And the US trend is more antidromic, the UK trend is more orthodromic. But it depends. Sometimes if you are not getting depending on if there's edema, you're not getting one way, you can try the other one and vice versa. It doesn't matter. But remember that you're comparing them accordingly to their own normative data. Okay. Now, one question is that, so once you record that, then you do few recordings and you sort of try to, let us follow them now further. So nice response there. Let me just remove this. It's coming on the. So you can see over there what happened, that there was a bit of a muscle response. Let me go back. So this was the antidromic response. I am seeing some muscle late response. Now, as long as it is not interfering with my main response, it's okay. But I turned around my endode a bit, I adjusted my slided a bit, and I see that is going now. And then it comes back, but it's still, I have a good response over there. Okay. And then you see this waveform is a bit wavy. Okay. So what I do is then I average out, I record 5 to 10 responses, and it becomes more smooth. It will show more over here. So now we have a more smooth response, and I adjust my accordingly the cursor at the onset. Over here you can see, oh, it's already finished. So here, if you see over here, this waveform is very wavy. Once I get my height of the response, I don't increase any further. So in Sensi, you don't need to go supramax. Okay, just maximum is now I'm averaging. See how it smooths out. The waveform smooths out, and you get a nice smooth response, and then you sort of measure the distance. This is just showing another picture. So what you're measuring over here is the onset latencies and the peak latencies. You have to measure both. This is the conduction velocity, and this is the amplitude, and this is the conduction velocity. Bigger response, antidromic; smaller response, orthodromic. Again, onset and peak latencies, amplitude, conduction velocities. Okay. So this is how it looks like on the machine. Now, important question, why is the amplitude higher in antidromic and orthodromic? Look, where did we place the electrodes for antidromic? We placed them on the digital nerve. When we were doing antidromic, we were stimulating the main trunk at this end. We were stimulating at this end, at the wrist, but we placed the electrode over here. Now here, the electrode is placed on the digit. It is directly over the nerve because the nerve is just under the skin. And is very near to the nerve, so you get a bigger response in antidromic. When you are doing orthodromic, you're stimulating the nerve here, and you put the electrode on the nerve, on the main trunk, where you have tendons running, and you have fascia. So here the distance between the nerve and the electrode, the surface is more, and you get a smaller response. So that is the reason that antidromic has higher responses and orthodromic has lower responses. It's just a technical reason because of the way you record it. Clinical applications will be quick now because we have mostly covered the concepts.
Oh, never mind.
So we can tell in neuropathic lesions what type of sensory fiber, what type of fibers are involved. We can tell it's an axonal process. We can tell it's demyelinating, acquired, inherited. We can talk about temporal course, how long the problem has been going on for, because we know that nerve conduction drop off occurs. First, the CMAP goes down by day 5 to 6, and around 7 to 8, we see the sensory snaps going down as well. So usually it is very important to know that how long is the history, because if you do an early nerve conduction within 3 to 4 days, all your studies may be normal. So that is why when we get a patient with GPS, we always ask how many days is history, and we want to give you more information. We want to know if this study is giving good information to help you your treatment and prognosis. Is it demyelinating? Is it axonal? If I do an early study, I don't have that information, then it is not going to help you in your management. Look, when you suspect clinically, you treat the patient if it is GPS. You don't wait for nerve conduction study. So a lot of people ask me that, oh, we want to start IVIG, should we want early nerve conduction? Base your treatment on clinical. Don't base your treatment on NCS. Now, sometimes you have a child who you cannot examine, history is not clear. Yes, that is a reason. Parents refuse LP, we cannot get CSF protein. Now you are in a dilemma, should you start, should not start, you want some information. If you have weakness, if you have clinical weakness in day 3, day 4, around -4, then do the nerve conduction as well. Because I have seen even in 3 days time, patients who are weak bedbound, their amplitudes drop axonal in AMAN, in acute motor axonal neuropathy, AMAN variant. So the rule is not always true, but usually we take around 8 to 10 days for the nerve NCS to be abnormal, and we prefer to do it after 8 to 10 days so that we can identify the abnormality very well. That is one thing. Also important in time of nerve injury, laceration nerve injury. In rehab, you get this a lot, I'm sure, nerve injuries. So it's very, very important to know this timeline, because you want to look for an early nerve conduction, which is few weeks after injury, so you can tell the pathology. And then you want to repeat it after a month or two to see if that pathology is the same, or if there's any reinnervation happening or not, or if they have done any surgery, surgical repair. So that is how you timeline. So in nerve injury, it's very, very important that you do at least 3 sets of nerve conduction studies. One in few weeks time. If you have done some repair, then after 1 or 2 months time, so you see early reinnervation. And then further down, if you see that the distal nerves are still not supplied, this is with both NCS and EMG together, obviously. Only NCS will not give you the whole information. You cannot confirm reinnervation on only NCS. You have to do EMG. But this is giving you the timeline and how you can tell temporal dispersion. This we already discussed before, that we can, when we consider a preganglionic lesion involving anterior horn cell or the nerve roots, we come back over here, we want to see normal sensory responses. So if the lesion is involving the nerve roots or the anterior horn cell, it is a preganglionic lesion. Your dorsal root ganglion is spared. So your snaps are normal, okay? But if your dorsal root ganglion is damaged, then it's a postganglionic lesion and your snaps will be abnormal. Now, nothing is absolute in medicine. We know that. So when we look at L5 radiculopathy, about 20 to 25% of the time, the disc may go laterally, herniate, and may damage the dorsal root ganglion. And we may get a low snap in the sense superficial peroneal response. In S1 radiculopathy, sometimes even in 1 to 2% of the time, a sural snap can be low. So having said that, preganglionic snap should be normal, but some exceptions are there. So you will be guided clinically, and you have EMG to confirm if this is radiculopathy by doing more EMG muscles or whatever. But it is a general rule, we say that the preganglionic lesion, the sensory responses are normal. And this is the reason, just the same diagram showing you. So this is no lesion, spinal cord, dorsal root ganglion, this is the nerve root, you get a normal snap, normal sensation. Preganglionic lesion, the sensory root is involved, but the dorsal root ganglion is not damaged. So because the root is involved, you get abnormal sensation, but your snap is normal. But when you go to postganglionic lesion, here is where that the dorsal root ganglion is cut off from the sensory nerve and the snap is abnormal here. Okay, so just the same concept. Okay, abnormal patterns. This is normal, showing you over here. You can see on this scale is around 10 milliamps amplitude, normal distal latency, normal run velocity. Here we see a drastic drop in the amplitudes. So the Cmap has dropped, whereas the conduction velocity is still normal, 50. Although it's reduced from 59 to 50, borderline delay in distal. So some people say that, oh, there is some delay in latency, this is demyelinating. No, this is not demyelinating. Mild delay you ignore, and we'll come to the criteria in the next slide. So this is a axonal lesion, axonal neuropathy. Here, if you look at all the responses are delayed uniformly, very much delayed. So that the distal latency is 12.7. Normal here was 3. Second one is similarly delayed, and you get a conduction velocity because if this is prolonged, then this will go down. Inversely proportional, as we made our concept, 12 meters per second. So this is demyelinating neuropathy, but there is no dispersion. So this is hereditary demyelinating neuropathy, as compared to the lower one, where we see good temporal dispersion, we see conduction block, the drop in amplitude height, as well as area they are not showing. We assume the area has dropped as well. But when we see this pattern, so temporal dispersion is a pattern. You look at the waveform. You cannot I cannot see a table and say this is temporal dispersion. Yes, duration will be prolonged, but I have to see how the prolongation is. The prolongation has to be in a dispersed pattern. And this pattern, it will tell me this is temporal dispersion. And that is why in a report which is not showing you waveforms, you're not sure what you're looking at. It's very, very important to look at the waveforms. And when we look at the conduction velocity, we see that the typical axonal loss is random dropout. Okay, we see that the conduction velocity is reduced, but still fast fibers are there. So that is why you have severe axonal loss over here, low amplitudes, but conduction is still 51 because some of the fast fibers are still there and they're conducting their normal conduction velocity. So you really, when the conduction velocity drops, is that when you have severe axonal loss of fast fibers, there's Wallerian degeneration in towards the later stages or advanced neuropathy in axonal, then conduction velocities start to become slow. So summary, abnormal patterns for axonal polyneuropathy usually mostly drop in Cmaps. Okay, by the time you are recording, most of the sensory responses are absent because sensory responses are smaller in microvolts. They are more prone to injury. They disappear early on. But as you see 3 arrows down going that very severe drop in Cmaps. Whereas borderline normal latency can happen or normal or latency can be normal and conduction velocity can be normal or borderline reduced. Okay, so axonal is straightforward and simple, low Cmaps or snaps or absent snaps. In demyelinating, you see sometimes you can see a mild drop in Cmaps. Now again, Cmaps are very much vulnerable. They sort of drop down very early on or they disappear early on, even in mild to moderate demyelinating neuropathies because they are more vulnerable to. But it doesn't mean the process is axonal. So don't commit if the sensory response is absent. Oh, amplitude is absent. You said absent, low amplitude is axonal. No. For Cmaps, you don't apply the criteria on the snaps, on the sensory responses. You apply the demyelinating criteria of all these on the motor responses. So you look at the latency, and the latency is very prolonged. We made this concept already, 3 arrows up. Now, how much prolonged? We want to be at least more than 130% prolonged of upper limit of normal. So if your median normal is 4.0, 130% means that it will be 5.3 or more latency millisecond. So if I see upper limb latency is 5.5 or 6, I know these are automatically falling in demyelinating range. I don't have to calculate the percentage. So in your head, you keep these gross numbers and it's very easy to interpret them. Similarly, conduction velocity is significantly dropped. Okay. So in the upper limb, if it is 50, you have less than 35. Okay. So more than 75% of the lower limit of normal. And the same latency rule applies on the FF latency, more than 130% of upper limit of normal. So these are 4 criteria which will show you hereditary demyelinating neuropathy. And if you add conduction block and have more dispersion, it becomes a criteria for the acquired. So rest is the same. Going on to technical aspects, I think we have half an hour more. So we will be able to finish in time and then take some questions. Now, we have technical aspects. The nerve can be affected when we are recording by physiological factors, by non-physiological factors, the whole list of them. I'm going to go and touch on the important ones, okay? So most important one is temperature. So the cooler the temperature, there is delayed inactivation of the sodium channels and the sodium remains inside for a longer duration, which causes higher current to be formed and increases the depolarization, and you have a higher amplitude and a prolonged duration. Okay, but what happens is that the conduction is slowed. Okay, so although you have large influx of sodium causing increased duration and amplitude, but overall the conduction or the latency is prolonged and the conduction velocity slows down a bit. So look over here at 27 degrees centigrade, this response is delayed. Distal latency is 3.1, conduction velocity is 42. Amplitude duration is 3.0 millisecond, good big amplitude. When we correct this temperature to 33 degrees, we see that there's a shift. The whole response shifts to this side. Okay, so myelin is functioning better. You get 2.5 normal latency, normal conduction velocity. In latency was still normal there, but it becomes faster, quicker, and your conduction velocity improves. Duration has become more slim because the sodium did not remain for longer time inside. It has a normal sort of a duration and amplitude drops down to normal as well. Okay, and this is the formula that you can correct the sensory velocity, the conduction velocity for 1.5 to 2.5 millisecond for every drop of 1 degree in temperature. And similarly, 0.2 millisecond you can add to every prolongation to the latency. You can correct it for every degree in drop in temperature. The pitfall is that you may diagnose wrong. You may have misdiagnosis. You have peripheral neuropathy where it was just uniform slowing. So whenever you see slowing, look, if it is a neuropathy, only slowing will not occur. The amplitude should drop. Here it is the opposite. You have slowing, but you have bigger amplitudes. This doesn't fit in with pathology. So always suspect uniform slowing is because of, and sometimes you feel the patient, they are not cold. So don't feel the patient. If you really want to do a good study, take the temperature. Use a laser temperature, or a lot of machines now have this temperature probe. You place it and they give you the temperature when they're recording. So good standards is always important to remember, and they help you with that. You may have a prolonged latency, and you may say this is carpal tunnel, and you may have the patient go through misleading diagnosis. They may have to do different sort of investigations, or even go through surgery for carpal tunnel. And the results are not comparable, because next time you come, the patient informed, you get normal results. The patient had nothing, and last time you reported a carpal tunnel and you feel bad about it, that you reported carpal tunnel, now this is normal and it was just temperature which caused this. So effect is slowing of the nerve conduction, prolonged distal latency, increased amplitude, increased duration. And these are all the measures. You know how to do this. Important thing, you have this electrical pads now, heating pads you can use very easily. Also, you can use what we use in the UK is wheat bag. Like wheat, like we make the flour and the bread from. The wheat comes in a small bag, and they have lavender or sandal or different sort of scents in it. And you just take the wheat bag, put it in microwave for 2 minutes, and you put it. It's very flexible. It wraps around the hand and the foot, and you leave it for 5 to 10, 15 minutes. It's perfect. It doesn't, very safe to use, very simple. You can order it on eBay or Amazon very easily. Now, important thing is, the best thing I still think is warm water, but sometimes I have also experienced this during my training, that there was a patient with autonomic neuropathy. He did not feel it. The water was very hot. He did not complain because he could not feel anything, and he developed sort of burns because of it. So you have to be careful. In the UK, when we were practicing, we no more use water for heating because it's not infection control sort of, doesn't allow us to do that. But still, I think it's good because it cleans the feet. It removes all the dry skin, the lotions and the creams. It becomes nice, clean, warm feet, and also takes away the smell if there's any in the feet. So it's very good, but you have to be cautious that you don't sort of burn the patient. Let them, if they're not feeling at all, don't use warm water because it can hurt them. Age is important to know. We know that normal myelination occurs when we are little, when we are children. The myelination occurs in, and the myelin is deposited with small, very narrow sort of, nodes of Zenware. Okay, and then we grow. So the same sort of, nerve grows, and the myelin prolongs. It was deposited initially as a childhood like this. When we grow, it becomes, the distances increase. And now, if you imagine, if I take small steps, it will take more time to me to get to one place. If I take bigger steps now, I get earlier. So that is how we get salutary conduction in fast conducting fibers. And this is why when demyelination occurs, our remyelination still follows the in utero sort of rule. And although remyelination occurs, here we have small nodes of Zenware. So some slowing is always persisting over there. So important to note is around 3 from at birth, the conduction velocities are around 25 to 30 meter per second. Now, if you see this in 1 year old, don't get panic. This is demyelinating neuropathy because I said it is in that range. No, this is normal for the age. Very important to remember. When does the nerve conduction become normal? At age of 3 to 5. At age 3 to 5, you apply your normal live data. Okay. And then when you go 60 above, again, it becomes to drop. Similarly for CMAPs, above 70 years of age, 50% of the snaps can drop. So if somebody with 70 years age coming with diabetes, if you don't record a sural or you record a small sural, that's normal for him. I usually say somebody above 65 or 70, they have a sural, it is a bonus. So don't label them neuropathy, because look at their age as well. It's very, very important. And obviously, you're always looking at the clinical aspect. Height, longer the limb, longer the nerve, narrower, thin myelin, nerves taper as they and limbs become cold, so conduction velocity becomes low. That is why we say that the sural's conduction velocity is around 5 millimeter per second slower than the median. Peroneal is 6 to, and tibial motors are 6 to 9 millimeters slower than ulnar. So you always have to adjust it for the height as well. Some of the normative data you have is height adjusted as well, especially when you're looking at F latencies. So it is important to note. Coming to the non-physiological factors, this one is important. A lot of time we are doing nerve conduction studies in a lab or in a ICU hostile environment. We are surrounded by many cables. We have cables, ICU setup, lights, this fluorescent lights, different lights. And all of this environment is very hostile for our sensory and motor responses, for our recordings. We call this alternating current, which is going all around, AC current, and it gives AC current noise or impedance, which is in some countries 60 hertz, some countries 50 hertz. Now, if you go back to my initial slide where I explained differential amplifier, I'll just take that example and explain how this can impact you and how you can get rid of it. So if you look at input 1 and input 2, this is active and this is reference. Both of them are recording. We know that the electrical sort of action potential is occurring under the G1 or the active electrode, whereas the tendon one on the, which is on the tendon, is not recording anything. So the differential amplifier look at this one and this one's and look at the difference and gives us the amplified version of the difference, which is the whole response. Okay. Now, in this example too, the 60 Hz artifact is affecting the electrodes. Okay, but we have this sort of resistors there, and which again we see that the both input 1 and input 2, they have the same sort of resistance. So we clean the skin, we sort of remove the dry skin, we put the gel, and now we know that the electrode is touching the skin and the nerve to the same extent in both electrodes. So the impedance or the resistance between them is the same. If it is the same, the electrical noise is affecting both the input or both the electrode to the same extent. So it is the same waveform here. If I draw on it, same waveform here, same waveform here. They will cancel with differential amplifier. You get your interest of signal of interest. But if what happens is that G2 electrode was loose, we did not clean it very well, there was some dry skin there, it was not very well placed, here there is more disturbance. Now this is not equal to this, and this will now not equally cancel out as it was cancelled out in this example. And it is also, so the amplifier looks at it as a difference and it will amplify it and project it. And now you have it overriding signal and you cannot see your signal of interest very well. So that is why what has happened over here, that there is impedance mismatch, and which is very, very important. That the first thing I do honestly is that I take alcohol swabs and I scrub the skin of the patient. I clean wherever I have to put my electrodes, I clean beforehand. I clean my whole foot, both feet together in one go. And even where I'm going to stimulate, I rub there as well. Because some of the people may be having Vaseline. You know, if you have Vaseline, my God, you have a very bad day that day for that patient. Because you need to really, so I clean with sort of, you know, sometimes you have old patient with dry skin. So you have this small sandpaper as a roll. You stick it on the skin and you rub it very slightly. It all dries. Then I use alcohol swab. Then I use tissue dipped in water and clean it. And then I sort of use a dry tissue and dry it. And then I start nerve conduction studies. And when I look at that small window in my sensory nerve conduction, I see a very nice baseline. And when I start with that baseline, I know that I am not going to encounter technical artifacts. So all that I said is what? That you should have the same active and reference electrode. Don't use different types. Ensure all leads are, wires are intact. They are not broken. Clean all dirt, oil from the skin using alcohol, acetone. Apply conducting gel between skin and electrodes. Secure electrodes firmly. place the ground between stimulator, use coaxial cable, and I'll show this again. So coaxial cable is that the cable I showed you in my video is one cable with two ends at the end, not two different cables for active and reference. Okay, so coaxial cable, you insulate it, you have a better chances, less chances of interference from the environment. Same to reduce noise in sensory recording, cable management, very important. Roll them up, stuff them under the arm, or put a tape over them. Don't let them spread out. If they spread out, they are like antennas. They're getting more sort of, contamination from the surrounding. Unplug unused equipment. In ICU setting, unplug whatever is not used. Look, even if the nurse say, oh, I've switched it off, it's not enough. If it is switched off, but it's plugged inside, it is an antenna carrying the AC disturbance. So unplug it, okay? And sometimes use your plug and put it in a far away distance socket, away from the bed. The bed is the most important culprit. You have to unplug the bed, the first thing you do in ICU setting, or even in your clinic. If your bed is plugged in, you will get artifact. Use incandescent lights, fluorescent lights, and dimmer switches, all are contributing to the noise, okay? Averaging, I showed you that, if you record single responses this, then you average, it summates the responses and it makes it smooth. We use this routinely in average. Now, if I do a first sensory response, patient relax, the baseline has no noise, I get a nice response, I don't need to average, okay? Sometimes averaging will cause cutting of your response. So if you see that your response is cutting and you're losing your amplitude, then you just stop the average because you want the best amplitude as well. So you have to use it with some concern. Again, this is stimulus artifact, very important. See, here we are stimulating, we have a positive deflection, we have a negative deflection. Here is sort of, we turn the the stimulus is affecting here. So falsely we get a smaller amplitude and a prolonged latency. Here we may get a falsely higher amplitude and a lesser latency. So our baseline has to be straight like this one. So this is the one that we go for. And how can you do that? This is very important. Again, ground between the electrode, stimulator and recording electrodes, reducing the impedance by cleaning it, coaxial cable as we said, okay? And the stimulator position is directly on the nerve. And start with lower stimulus intensity so that the stimulus artifact doesn't travel much to the recording response, okay? And then closing. And most importantly is this one, rotate anode. And this is something that, when the anode is placed, what you do is that where you have the cathode, you put a small pen mark on it, okay? And then you turn the anode gradually. When you turn the anode gradually, you try to sort of, you may have a response like this. So the response is like this. So there is an overriding response over here. It's on a slope, okay? So your cathode and anode is placed like this. You keep the cathode at the same place, but you shift your anode slightly, okay, maybe 45 degrees. And you see this response, sorry, this response is now like this. You shift further, this response becomes like this. So you want to mark out which is the one that you will take where you have a straighter sort of an uptake. So make sure that your cathode remains at the same point and you rotate the anode. And sometimes you may be surprised, you have to rotate the anode more than 180 degrees or even up to 180 degrees, which is almost half a circle, okay? But always make sure that you don't lose your nerve. Your cathode remains on the nerve and you don't lose the response. Sometimes if stimulus artifact is not going away, increase the distance between the stimulating and recording. And again, don't overlap. Cable management is very, very important. Look, it is a myth. You have to do the job in a clean fashion. Your cables should not be spread around. Your stimulator wire should not be crossing the cables. Everything should be in its place. It should be a neat job. When you do a neat job, you get a neat response. It's very simple. So same things, I think nothing new over there. One thing I will mention, this is in Nicolay Quest or Nicolay, they have this signal enhancer. So see, if you have a signal which is like this, overriding on a slope like this, what the software does, it detects this wave and subtract it out, and then you have a waveform which is like this. So what is taken out is something like this. So this is not a filter. It is not going to disturb your signal of interest. Okay. Some people think it's a filter. No, no, it is not distort. It's a mathematical algorithm. It will take out this artifact, detect it. And honestly, it is a blessing. If you have signal enhancer, it is a blessing in your machine. I use it all the time. And a lot of time in ICU, other setup, you know, your response is writing like this. Your response is writing like this. You just use signal enhancer and you'll become very nice clean response. So this is the effect of coaxial cable. Nice smooth response, free wires. You see that the stimulus artifact is coming there and distorting the uptake. Co-stimulation is very important. I mentioned this initially where I was showing you the motor responses. What you have to watch is abrupt change in the waveform morphology. So you're recording responses like this. When you go proximal, you record one like this. You increase intensity, you get this. Then you give further intensity, you get something like this. Now this shouldering which has come is co-stimulation. Okay, so always watch. So if I have this response here, and then I have this response, it's different shape. So I said this is say 10 millivolts, this is 5, this conduction block. No, you want the conduction block smaller in the same shape. You don't want this sort of, you know, shouldering or this notches coming up, because it means that you're co-stimulating some other. Very, very important. So always use small intensities and increment in small gradations and watch the waveform, how it is changing. Whenever you see any shoulder developing, you know that you're co-stimulating. So to reduce motor artifact, prevent electrodes touching each other, especially ulnar sensory, ulnar nerve electrodes, we place some gauze over there and ulnar antidromic, so that you don't get the contamination. Sometimes you place the electrodes far from the muscle. So if this is your little finger here, this is rest of the hand. If you're placing very near the start of the finger, you will get the muscle contamination. So place it a bit distal. And if you can use ring electrode, is the best. I think the ring electrodes are the best for recording all digit responses sensory. And you can place this right at the finger, you know, tip, the reference. Relax the patient, use average, and in some machines you can record it, and each response you can go and edit offline analysis and remove the one which was contaminated by muscle, and your signal cleans out. So you can do offline sort of editing as well. I think initial deflection important. So when we do motor, I did mention this at that time, but see, we want the motor response to be placed on the end plate region where the response is initiating. So that is why you get an upright response. If you are away from a motor end plate, then the response will travel to you and you will get a positive deflection. So if I'm recording a motor response, I want this response, not this. So I will move my electrode around until I get this. Similarly, tibial recording from abductor hemolysis, you don't want this positive deflection. In some nerve recording like ulnar, you cannot get away with it. Okay, sometimes the reference is not inactive and it is contributing sometimes. Okay, so you may not be able to get rid of it all the time, but at least in median nerve conduction studies, you want to be on the end plate region and you want to avoid this positive deflection. Move your electrode around a bit so that you can do that. Again, this is showing you edema. So this is normal distance between the nerve, you know, when you're recording and the electrode, but in edema it is increased. So this is the same effect that we talked about antidromic, orthodromic, why amplitude is high. Because there's edema, there's more distance, so you get a smaller response. So be sure that if there's edema, you don't call your study abnormal and you say that, you know, we may repeat the study, don't label them, don't commit type 1 error, be careful with that. So this is summarize of all our electrical responses. I think this will be the last slide. Ambient noise, we said reduce electrode impedance, equalize the noise, manage cable management is very, very important. Very, very important. Root ground connection, unplug unused equipment, lights we already discussed. This slide again, stimulus artifact, how we can reduce it by drying the skin, reduce intensity, cable management, ground between the recording and stimulation, anode and signal enhancer we covered, motor artifact, we can place the electrodes away, prevent the electrodes from touching other sites, and EMG artifact by using signal averaging, relaxing the patient. This summary is again from Sanjeev's presentation from one of his lectures. It's a very good summary to keep. You can make this slide and put it on your sort of, in your recording room for teach student technology to learn from. So we've covered an approach. Just to summarize, we looked at how important it is to consider clinical electrophysiological correlation. And we have to keep our approach dynamic. We look at the results, we look at our differential, and we may need to do more nerve conduction studies or less. We need to do nerve conduction studies with expertise. It is not anybody can get a machine and start to do nerve conduction studies. Our technologists are experts. They are our helpers. They give us very good quality data. They spend years of training in achieving this. We use standardized techniques. Don't just place the electrode and stimulate anywhere. No, there are manuals available to look at that. And ideally, you should have normative data from your population to compare with. Important clinical applications for nerve conduction alone is that entrapment neuropathy, CTS, neuropathies, all types. You do not necessarily EMG until you have another indication to rule out. Important technical aspects is that at the end, your study should be meticulous. And what Eric Starberg used to say when I was training with him as well is that even whatever you do, your waveform, you are able to publish it in a paper. If you do that quality, you will always have very good nerve conduction studies. And I think that was my last slide. Thank you for Nandecker Productions for keeping those things free, resource material, so that we can learn from it during this time and with their acknowledgement and permission. And I will leave with the last slide where soon I will be launching a website, Neurophys Care, where you will have courses, updates, other sort of things. So keep this out. Those are my contacts. And my email for further sort of questions if I cannot answer today. We have 5 minutes or more, but we can take questions. For me, I have as much time as you want me to be here, but I will take questions now. And you can always email me questions later on, and I will try to reply them. Thank you so much for your time and attention.
Okay, in this isolation time, I need to thank you, Dr. Sajjad Ali, for this amazing talk. You cover all of the aspects of the conduction study, different bits and also the tricks and also the pitfalls. All technical aspects I listening from Professor Kimura, Professor Starberg, and all. This is very interesting talk. We are all never ever leave our attention for your talk. I think any questions, I will gather it and collect it for you and send it. Hoping another appointment from you in after Eid. وكل عام وحضراتكم طيبين. Again, thanks Dr. Sajjad for this amazing talk again and again, and hoping good feast and see you soon. Thank you.
Thank you.
Okay. Assalamu alaikum.
Wa alaikum salam.